Okay, let's jump straight into the next best step logic for small vessel vasculitis on step 2CK. When you're evaluating a systemic presentation, you've really got to do three things: identify the vessel's size, categorize the disease using immunologic markers, and then nail down that next best step in management based on biopsy and serology. Now, your absolute highest yield clinical anchor here is palpable purpura. This is your red flag that inflammation has actually breached those small vessels, allowing erythrocytes to extravasate right into the surrounding tissue. And because this blood is physically outside the vessels, the lesions won't blanch when you apply pressure. That's exactly how you establish small vessel involvement. Next, you want to pair that palpable purpura with kidney clues. If you see a rising creatinine or new-onset hypertension, that mandates a urinalysis to check for glomerular hematuria. You're looking specifically for red blood cell casts and dysmorphic red blood cells. Finding those confirms bleeding right at the glomerular level, which gives you that classic pulmonary renal or systemic renal presentation. So how do we sort these out? The diagnostic pathway branches based on immunology. You need to ask yourself, does this patient have immune complex disease with low complement? Or is it a posse immune disease driven by ANCA? Or, third option, are we looking at an IgA-driven disease where the complement levels are totally normal? Let's start down the immune complex branch. Mixed cryoglobulinemia, specifically types I and III, presents as a true immune complex vasculitis. You want to contrast this with type 1. Type 1 is driven more by plasma cell dyscrasias causing hyperviscosity, which gives you livedo reticularis, retiform purpura, and digital ischemia rather than true vasculitis. For mixed cryoglobulinemia, the mechanism is basically B-cell hyperactivation. You have IgM rheumatoid factor binding to polyclonal IgG, which forms these immune complexes that precipitate in the cold and deposit in small vessels. On the boards, this is classically triggered by chronic viremia. Think hepatitis C or HIV, or autoimmune conditions like SLE and Sjogren's syndrome. Clinically, keep an eye out for the Meltzer triad. That's purpura, weakness, and arthralgia, which shows up in about 80% of these patients. You'll also see peripheral neuropathy and glomerulonephritis, but watch out for exam traps. You might see profoundly low C4 levels and a positive rheumatoid factor just because of that IgM activity. Another tricky one, a positive cryocrit can actually take up to 72 hours to precipitate in the lab, so don't rule it out too early.
When it comes to treatment, it is strictly sequential. If there's severe end organ damage, like a rapidly worsening glomerulonephritis, you have to stabilize that immediately with immunosuppressants, typically rituximab plus prednisone. You only initiate antiviral therapy for the underlying trigger, like HCV, after the vasculitis is fully stabilized. All right, let's pivot to the posse immune pathway. This is a big shift away from low complement immune complex deposition. On immunofluorescence, you'll see few to no immune complexes. Instead, the tissue damage here is driven by anti-neutrophil cytoplasmic antibodies, or ANCA.
A major player here is granulomatosis with polyangiitis, or GPA, which causes a necrotizing granulomatous inflammation. You should expect destruction in three key areas: upper airway issues like chronic sinusitis, nasal ulcers, and saddle nose deformity; lower airway findings like lung nodules, cavitations, and hemoptysis; and in the kidneys, you'll see rapidly progressive glomerulonephritis.
Now, GPA is heavily associated with PR3 ANCA, but you definitely need to know the MPO ANCA exceptions. If a patient has a pulmonary renal syndrome with capillaritis, but they don't have those destructive ENT granulomas, you should be thinking microscopic polyangiitis, or MPA. Alternatively, if they present with new adult-onset asthma, severe allergic rhinitis, really high eosinophils, mononeuritis multiplex, and cardiac involvement, think eGPA. And remember, cardiac disease in eGPA is a major danger that requires immediate systemic glucocorticoids. Definitive diagnosis for these relies on a biopsy, and the histologic findings change completely depending on where you sample. A skin biopsy is going to show leukocytoclastic vasculitis. A kidney biopsy reveals pauci-immune glomerulonephritis. But to see that classic granulomatous vasculitis in GPA, you typically need to biopsy the lung. To halt rapidly progressive end organ damage, the immediate next best step is hitting it hard with corticosteroids combined with an immunomodulator, usually cyclophosphamide or rituximab. If the disease is a bit less severe and their renal function allows it, using methotrexate combined with steroids is another valid option. Let's move to our third and final category: normal complement IgA-mediated disease. These patients will present with all the classic small vessel vasculitis symptoms. But when you check their labs, they retain normal coagulation, normal platelets, and normal complement levels.
This brings us to IgA vasculitis, which you probably know as Henoch-Schulman purpura. It classically presents with lower extremity palpable purpura or petechia. Pathophysiologically, we're looking at a leukocytoclastic vasculitis caused by perivenular deposition of IgA, C3, and fibrin. Beyond the skin, you've got to screen for the classic systemic tetrad: the rash, arthralgias or arthritis, severe abdominal pain, and renal disease that looks identical to IgA nephropathy. You should also check for scrotal swelling and pain, which is especially common in younger patients.
Watch out for these specific exam traps. Despite the purpura, platelet counts and coagulation studies will be strictly normal. Also, their initial urinalysis might be totally clear, but renal disease can actually pop up months later, meaning serial urinalysis follow-up is required. Finally, that severe abdominal pain might be due to small bowel ileo-ileal intussusception. Unlike other types, this generally won't reduce with an enema and requires surgical management.
Management for IgA vasculitis depends purely on severity. Mild cases with just the rash and some minor arthralgias just need supportive care, hydration, and NSAIDs. But if you see severe systemic disease, severe abdominal pain, or worsening renal function, that mandates hospital admission and systemic glucocorticoids.
To wrap this explainer up, let's lock in the clinical comparisons that drive your next best step logic. Mixed cryo presents with neuropathy, low C4, and an HCV history. GPA features destructive airway disease and PR3 ANCA. IgA vasculitis brings abdominal pain with normal platelets and coags. Identify your clinical anchor, check the immunologic marker, and sequence your treatment accordingly to secure those points.